Wonderful to see so many people here today. I know it's an important topic. I'm going to pass off to Evelyn Nelson, who is the principal investigator with Heartland Telehealth Resource Center, to get us started today.
Super. Happy New Year, everyone. We're glad to start off the new year with you all. And as Rochelle and I were talking right before the presentation, I couldn't think of a hotter topic. So we're so fortunate to have you with us today. Just a few house cleaning before we get rolling. The session is being recorded and we'll share it with you after the presentation. Your microphones have been muted. As you do have questions, please do type in the chat. Also, we appreciate if you can change your name so we know who's on the presentation with us today. We appreciate keeping your cameras on if you can. It really helps us to get to know folks on the webinar series. After the presentation, we'll keep in touch with some surveys, and again, we'll share the session recording and resources after the presentation. So just to get rolling, I know many of you know Rochelle already. She's an attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing and reimbursement, HIPAA privacy and security, HIT management, and regulatory compliance. Again, really interested to hear what she has to share with us, and do keep us on our toes with questions in the chat. Thanks, Rochelle.
Absolutely, and happy to take any of those questions away. We're in this really interesting time where I was talking to Evelyn and Christy. It feels like we've kind of rewinded 2 years, and we're in March of 2020, and things are happening daily now. Where we, in terms of policy and regulations and coverage and changes, things were kind of steady for a while, and we had a little bit of a sense of where we were going when the PHE ends. And sort of feels like we are just back in the thick of it. So we're going to talk about some of those very recent changes that have happened, particularly with CMS, with the state Medicaid agencies, and some policy changes, and also just kind of where we are at with the different Medicaid flexibilities that went into effect when the state emergency declarations were originally announced back in 2020, that have since been allowed to expire or have been rescinded in each of the 3 states, Kansas, Missouri, and Oklahoma, that we're primarily talking about today, and how that impacts the state Medicaid coverage policies since those flexibilities went away. And we know that telehealth was a huge focus of some of those flexibilities that went into effect at that time. So getting kind of going into this presentation, I had flashbacks to the Wizard of Oz. We've got waivers and executive orders and declarations and flexibilities, and keeping track of those back in March through May of 2020, when it just seemed like there was a rapid fire of things happening literally almost daily between state and federal legislature, executive bodies, agencies, regulations, interim final rules. And we're seeing a little bit of that happening now as well. So I thought I'd kind of walk through from a federal and then each of the state levels where we are from that standpoint, and then how it's impacting the Medicaid policies that in particular have an impact on telehealth and telehealth delivery. So from a federal standpoint, the federal Department of Health and Human Services public health emergency is really the key emergency declaration that holds in place and sets the duration and the time frame for a lot of the Medicare telehealth rules and flexibilities that we have in place. So that was most recently renewed October 18th. So that took us into a 90-day period into mid-January. I very much expect, given our current COVID environment, that within the next week, when that would be set to expire, it could be coming out as soon as the end of this week, we will likely see confirmation that that's going to be renewed for another 90-day period. So that would take us into about mid-April of 2022 for the federal public health emergency. not only our current environment, but if you'll remember, mid last year, we talked about nothing that was binding, but informally, the Federal Department of Health and Human Services sent out a letter to each of the 50 state governors saying that they were their intent was to provide a 60-day notice before the federal public health emergency was going to end, to give governors notice, and we can then start to address any state executive orders or declarations, or kind of wind down at that point. To my knowledge, we haven't seen that statement from the Department of Health and Human Services. So all signs are pointing to this at a federal level being extended for another 90 days. So then in Kansas, we've had some interesting developments very recently after the new year. In Kansas, Governor Laura Kelly issued a brief 15-day emergency declaration order until the legislature could reconvene and potentially enact legislation. And Robert, you can probably speak to this change in process that happened, sort of butting heads between the executive branch and the legislative branch on the power or scope of authority of the governor to enter into a state of not perpetual emergency, but that's sort of how it was sort of characterized by the legislature, and statutory changes that shifted that power and authority from the governor to the legislature in certain circumstances. So this brief 15-day emergency declaration is really just intended to be sort of a gap until the legislature can come back and address the state of emergency in the state of Kansas. So anywhere that you see the blue text with links here on the slides, when we send the slides out, you'll have access to those links that will take you to the actual executive orders if you want to read their text in full. I've highlighted some of the key points as it pertains to telehealth, but of course, these are several pages long where you may want to review and see if there's anything additional that may be pertinent to your organization in these orders. So this 15-day temporary emergency declaration in Kansas went into effect January 6, 2022. So I would expect here in the next week or so, we would have some more information on what's going to happen at the end of that 15-day period. With that emergency declaration, two executive orders were created. The very first two in 2022 focused on healthcare organizations and how this ongoing surge of the COVID emergency and some flexibilities for healthcare providers. So highlighting a couple of provisions from those two executive orders. One is that any statutes related to the supervision, to the delegation, and those types of issues for healthcare providers are temporarily relaxed or suspended. So that primarily affects our physician assistants who have supervision requirements with their supervising physician, APRNs and their collaborative practice agreements and the supervision requirements under the licensing laws for those practitioners. In particular, also affects any supervision requirements for nurses who are collecting specimen for COVID testing. Allows pharmacists to step in and help with providing for routine health maintenance and chronic disease states. There are a few others in that executive order 2022-01, meaning the first executive order of 2022, that you may want to take a look at in terms of supervision. But we're right back to kind of where we were in March of 2020 in terms of suspending those supervision requirements temporarily. And again, that's for a 15-day period. And then we may see the licensing boards or the legislature come in and enact those flexibilities for a longer period of time. The next provision of this first executive order is really the focus of Executive Order 01 is staffing shortages. So this is trying to get as many bodies with experience, training, who can help out in healthcare organizations available as we can due to the significant staffing shortages that we're seeing kind of across the board. So this would also allow any students who have some training and some education and some experience in healthcare to come in and volunteer in whatever roles are necessary and appropriate and consistent with the education, training, and experience they have. So some thoughts or ways that I've seen that particular provision potentially implemented. Students can come help transport patient between units, going from the floor to radiology or to lab or to the OR, helping with, excuse me, COVID-19 vaccination clinics and administrative assistance there, whatever is appropriate. And the way that this is written temporarily for 15 days gives pretty broad discretion for those individuals working within healthcare organizations. Our licensure statutes, where remember with telehealth, we typically have the rule that the provider has to be licensed in the state where the patient is located, with some variations in that state to state. That requirement, professionals licensed in any state in good standing can temporarily practice in the state of Kansas. So that would include the delivery of telehealth in the state of Kansas. It says the executive order expands on that and clarifies that a suspended license in another state would not be good standing. And if there are restrictions on a practitioner's license in another state, that could still be good standing, but those restrictions would also apply to their practice in the state of Kansas. So some provisions of the second executive order, this is really creating flexibility for licensure of healthcare professionals. And essentially the key piece of this is extending licensure deadlines. So if you were a registered nurse with the deadline, your license was set to expire today, for example, it would extend the renewal dates, continuing education deadlines. I want to say it even waived some of the fee requirements for professional licensure, essentially really trying to make sure the focus is less on the administrative hoops to jump through and really making sure those folks are available for patient care as much as possible right now. So headed over to Missouri. Our update since our last session in Missouri is that the COVID-19 emergency declaration from the state governor was the last of the 3 states that we talk with on this call to still be in effect. And the governor allowed that to expire December 31st, 2021, despite the urging of hospitals and physicians and professional associations. What the state has said in terms of how that affects Mo HealthNet. Is the audio okay, Christy? I just got a little pop-up. Okay, that the connection was unstable. What Missouri HealthNet has said in terms of how the expiration of the state emergency order is going to affect all of the Missouri HealthNet telehealth policies and bulletins and hot tips that went into effect during the COVID emergency. The state has communicated to its health partners that there will be flexibility during this transitional period to fully resume to pre-pandemic operations. Some of the things that those waivers and flexibilities did during the state of Missouri's emergency declaration, it created reciprocity for professionals licensed in other states, where that reciprocity is gone with the expiration of the emergency declaration, reinstated geographic limits for advanced practice nurses in terms of their collaborative practice agreements. So there are provisions under those collaborative practice statutes and regulations in Missouri on how physically close in proximity in terms of geography the nurse practitioner and the collaborative physician have to be practicing, with the idea that that is an actual collaborative practice and not a remote physician that's kind of signing off on charts and signing off on the nurse practitioner's work. So those go back into effect. Now, the Missouri Hospital Association, whether your organization is a hospital or not, has a really great tracking tool. The links here that I encourage you to go to, that they're keeping updated as these things change. If you, at least when I was on this last night, there is one piece that has actually been updated in the last 24 hours that is different between the MHA's tracking tool and what you're going to see on Missouri Health Net's website. So the tracking tool said, with the executive order expiring December 31st, it wasn't really clear what impact that was going to have on all of the Missouri Health Net, Missouri Medicaid waivers, particularly, many of those did involve telehealth services. And so MHA's tracker says it's not clear which, if any, remain in effect. Just yesterday on Missouri Health Net's website, they posted a clarification and guidance to providers on exactly what that did mean for those Missouri Health Net policies. So the guidance on the Missouri Health Net website now says, while that state of emergency ended December 31st of 21, the Missouri Health Net or Missouri Health Department has to submit certain requests to CMS to discontinue some of those flexibilities. So right now, those flexibilities continue temporarily until the CMS approval to discontinue those flexibilities is granted. And then there will be updates when the state's approved to discontinue the two flexibilities listed above, meaning the reciprocity and reinstating geographical limits for APRNs.
And Rochelle, we've got a question in the chat.
Sure.
Okay, so this is from Carol, and Carol may need to clarify on what these codes are, but she's listed out several codes, G0425 through G0427, and G0508 and G0509 are being denied as non-covered, which is expected based on the fee schedule. The question is, do we anticipate that changing in the future?
I'm writing these codes down from the chat. And that may be one, if I don't have that on the slides here, that I can take away and research the coverage of those. And being denied as non-covered based on the fee schedule, did that changing? Carol, one question I may ask for clarification so that I can get an answer to you. Is that specifically when they're rendered via telehealth, or regardless of the modality that they're being delivered?
Those are actually telehealth specific codes.
Telehealth specific, okay. Telehealth. I have a lot of the codes memorized off the top of my head, and those are a few that I don't have the definitions memorized. So I will look at that, Carol, and I'll get a response out when we send the slides out.
Thanks so much.
Absolutely.
Rochelle. Hi, this is Jason from the University of Kansas Health
Hi,
System.
Jason.
Quick question about the last statement you made on the last slide. So just for clarification, and I think it's a wonderful thing that you pointed out. What you're saying is that CMS has jurisdiction over the state Medicaid program for making the decision of whether physicians' reciprocity APRN program actually is in fact not ended. Is that what you're saying?
My understanding from what Missouri Health Net posted on their website is a lot of the flexibilities that are particular to telehealth, they submitted, it must have been an 1135 waiver to CMS to get approval. And what I'm thinking, Jason, is from a licensing standpoint, if we remove Medicaid, we can have that flexibility at state law for Blue Cross and Aetna, for the unauthorized practice of medicine, that flexibility. But in order for Medicaid to pay for it, it must have been an 1135 waiver to get that approved. So to rescind or withdraw. Yeah, go ahead, Robert.
Well, Missouri didn't do an 1135 waiver, and I think that's why they've seen themselves in trouble here. Because they decided, because the state has a Medicaid parity law, they didn't need to do an 1135 waiver. So basically, in effect, they changed the state plan, right? And they didn't change it in relation to the emergency because they didn't feel they needed to. So I can see now that Medicaid, which CMS, which, you know, the Biden administration wants this stuff to continue, is saying you did a state plan change and now you have to tell us you want to reduce the coverage, right? So Medicaid accepted the expansion in coverage, but now Medicaid, when they're trying to withdraw it or reduce it back to pre-emergency levels, is saying, I think they probably have to do a state plan amendment because anytime you expand or reduce coverage under Medicaid, it requires a state plan amendment. So I would actually say, I think it's related to the fact that they chose not to do an 1135 waiver. But that's just
Interesting. Yeah, that could very well be. And I had not gone back to each state's actual 1135 waivers and what they had submitted and what pieces of the flexibilities were part of the waiver versus there was a CMS guidance on what you could do without submitting a waiver and where these particular provisions fell in. So that could very well be, Robert.
So Robert and Rochelle, just for clarification, are we saying potentially that our physicians who are not licensed in the state of Missouri actually can still potentially practice in Missouri, even though the expiration, or we're past December 31st?
So, okay, that's a great question. And Jason, I think it's two-part. There's going to be the physicians that are licensed in Missouri, or it would be, are you asking physicians licensed in Missouri that can see patients in Kansas, or the other way around?
The other way
if they
around.
are
Yeah,
licensed in Kansas, but not Missouri,
right?
Can they right now see patients via telehealth in the state of Missouri? So there's two parts, and let me go back and clarify the distinction on the executive orders and the licensure. So outside of Medicaid coverage for Blue Cross, Aetna, and all of the others, to confirm that is still allowed after, whether or not that's allowed after 12/31. And then the second piece of that is, if it's allowed outside of Medicaid, is it also going to continue to be allowed within Medicaid and paid within Medicaid if that Kansas physician is not licensed in Missouri, unless and until CMS allows Missouri Health Net to rescind that flexibility?
Perfect. Yes. Yes. Thank you. That would be huge to understand that.
Absolutely. I will double check those distinctions, both of those pieces.
Thank you.
I
And
love
while
this.
we're-
I love that I've got some follow-up research to do. Thank you so much for the questions.
Yeah, Rochelle loves it. So if you have other questions, feel free to put them in the chat. We've got one more while we're paused for questions here.
Sure.
Julie asks, in Kansas, a student waiting to test for their PMHNP or APRN could practice during this period. So the emergency period.
Yes, and I think that's specifically addressed in Executive Order 22-01, those that are waiting to test and what their capabilities are during that period when they otherwise have the education, training, and licensure. So those supervision requirements, there's two potential ways that they could fit into that executive order, either as students, as volunteers, or as healthcare professionals waiting to test. And I think each of those components are addressed in that executive order and the scope of what they're able to do, depending on which of those buckets they fall in. All right, so just for Missouri Medicaid, prior to the COVID public health emergency, prior to the state emergency declaration and the executive orders declaring a state of emergency in the state of Missouri, we had provisions for Missouri Medicaid that any licensed healthcare provider who is enrolled with Missouri Health Net could deliver telehealth and be paid for telehealth under Missouri Health Net. At the time we initially had discussed this last May, we were deep into the filling out the claim form. So I won't go through those particular entries on the claim form, but this guidance still is largely in effect for how we submit those telehealth claims, and some specific details on the place of service, where you put these codes on the claim form and when. One thing I will add that has not changed, but maybe expanded, is place of service 02 is the code that we had customarily used for telehealth services prior to COVID. And Medicaid agencies are still primarily using that code, although Medicare is not. Medicare wants us to use the place of service that would have been reported if that telehealth service had been rendered face-to-face. So that may be place of service 11 for office, or hospital outpatient department, hospital inpatient department. And the reason that Medicare has made that change is prior to COVID, when we use place of service 02, that triggered a payment rate at the lower facility-based payment rate for services if they were broken out into a facility and non-facility rate. So that resulted in a lower payment amount for services that would have otherwise been rendered in the office setting, like place of service 11. But during COVID, that payment differential went away, so that visits that would have otherwise been delivered in person, face-to-face in the office setting can still be eligible for the higher non-facility payment rate. But to do that, you have to report place of service 11 instead of place of service 02 for Medicare during the PHE. And that continues to be the Medicare guidance. Then I can't remember the month, it was August through October of 2021, there was actually a second telehealth place of service code created. So it had always been just place of service 02. Now there is a new place of service code 10 that can also be used for telehealth services specifically rendered to a patient in their home. We had a session a couple of months ago that talked about the distinction between place of service 02 and place of service 10. 02 is going to be telehealth other than the patient's home. 10 will be telehealth to a patient in the home. And it seems like the Medicaid agencies are likely going to also adopt that place of service 10. Whether private payers will also adopt it and utilize it is kind of yet to be seen, but that's something to keep in mind as well. So this is, again, ordinary Missouri Medicaid rules, absent all of the waivers and flexibilities. There were guidelines that the same provider can bill for both a distant site professional service as well as the originating site fee, as long as the distant site is not within the same facility. So for example, the patient can't be in one room and the provider in another room, and we're billing for both the distant and the originating site. But if it is a hospital, and the patient, the originating site is in the clinic and the physician is located in the hospital setting, the hospital billing for both the professional and the originating site fee could occur. And that came up quite a bit with community mental health centers also because of their geographical spread. Rural health clinics could report as originating sites using their Missouri HealthNet non-RHC provider number. I won't bore you with the claim details, but there was a screenshot from the guidance there. Federally qualified health centers would just their end of year cost reporting would take out all of those originating site fees from telehealth services from their end of year cost report. So the changes from Missouri HealthNet,
Rochelle, before we move on to that, do have a question in the chat.
Sure, let's do it.
Okay, so can Missouri licensed dietitians continue to provide telehealth to Medicaid patients?
As of today, the guidance that we have on that is it doesn't appear to have changed yet. So if they were allowed to do it during the state of emergency in Missouri, we don't have any indication that that policy has been rescinded, but we're going to have to watch closely on the Missouri Health Net website. The links here to the hot tip index and to the bulletins that they publish are going to be happening as policies are rescinded, as policies are changed, or as the flexibilities that were made available during the state of emergency in Missouri are potentially made permit coverage options. So I don't have any indication that that added flexibility, if it was there during COVID, has gone away yet.
Thank you.
Absolutely. And there's going back a couple of slides here on the MHA, Missouri Hospitalization Association waiver tracking tool. They have tabs by topic, and one of them is healthcare professionals, and it's really helpful to break down different waivers by discipline. There were some for teledentistry. So if you have a particular discipline and licensure and coverage issue, that's a great tab to check on the latest updates as well. Keeping in mind, you may want to double check both Missouri Hospital Association as well as this COVID-19 hot tip index on Missouri Health Net site. Because like I said, as of yesterday, Missouri Hospital Association said it wasn't clear, but Missouri Health Net had just posted an update on their website just yesterday. As of yesterday, which could have changed by the time we joined this session at noon today, none of those hot tips that had COVID waivers, COVID flexibilities, and COVID changes had been modified since the December 31st, 2021 expiration of the state executive order creating a state of emergency in Missouri. But that is a page that you'll want to keep tabs on and check periodically. Subscribe to Missouri Health Net, subscribe to any of the state agencies, newsletter and bulletin updates and listservs to keep up with the latest, because I do anticipate there's going to be a lot of changes between our 15-day temporary emergency in Kansas and the expiration in Missouri. We're just going to be in a state of fluctuation and flexibility here in the coming weeks and months, I think. There was a bulletin that was published. So on Missouri Health Net, we have hot tips and we have bulletins that you'll want to keep track of both of those, published just yesterday, clarifying that that an originating site fee cannot be billed and reported if the patient is at home. And that's pretty typical and consistent with with the way other payers are handling originating site fees. The idea being there's not administrative overhead for that location, and there's typically an exception if you have a staff person who is there on site with the patient at home, that could potentially be a reportable originating site fee, but that's not the typical circumstance. There's no separate telehealth fee schedule. So that creates payment parity under the Missouri Health Net program, that when you render a service via telehealth, you're not going to find a separate payment rate when place of service is 0, 2, or 10 when the service is delivered by telehealth. Whatever code you've reported, an office visit code, for example, is going to get paid the same rate regardless of the modality of delivery under the Missouri Health Net program. Now, the big one that everyone's interested in with these flexibilities in flux, coming and going and expiring and temporary in Kansas, is what happens to audio only coverage of telehealth services. So nothing has changed from the Medicare perspective right now. Anything that was allowed as audio only under the Medicare fee schedule will continue to be allowed audio only in accordance with the fee schedule. And we did a session a couple of weeks ago on the changes for 2022, extending into 2023, and how audio only is impacted. So if you're interested in that for Medicare, you can pull up that session on the HTRC website, and it's got some very particular nuances in the behavioral health arena in particular to pay attention to. So for Missouri Health Net, then Missouri Health Department allowed the use of telephone audio only for telehealth services, and allowed quarantine providers or providers that were working at alternative sites because of quarantine or reducing exposure to provide and to bill for those telehealth services. They can continue to be billed as distant site services using the provider or the clinic's Missouri Health Net provider number. So, Robert, this is a little bit about the kind of political and policy dynamic you're talking about. This was just posted yesterday on Health Net's website. The Missouri Health Department did not require any additional CMS flexibility for these options, and they will continue. So that's the latest from Missouri Health Net as of yesterday. Whether CMS agrees that did not require flexibility, to be determined. Although I don't think that's something that Missouri or that CMS is going to challenge, because they're wanting those flexibilities to continue right now. But if they wanted to take that away, that could potentially, Robert, be something that they have to submit as a plan amendment, and we would have to see if CMS would approve or not approve that change.
And I don't know if you saw in the chat, but when I went and looked at Missouri's 1135 approval, and the out-of-state providers was granted for the duration of the public health emergency. So I bet they're saying, well, the public health emergency is not over, so you can't do this.
Okay, so that's going to go to kind of part two of Jason's question, that piece was in one of the Missouri waivers, but that would have been specific to the Medicaid program. So I'll have to look at the status on the from a state licensing perspective, where they stand on that with the emergency state expiring 12/31 outside of the Medicaid program.
I would bet when the feds reference the public health emergency, they're talking about theirs, right? Because the waivers.
Yes, I agree. So the interesting piece of that then is, if it has to be allowed for Missouri Health Net, for Missouri Medicaid, there would almost have to be a carve out from a licensing standpoint outside of Medicaid coverage that, it's only allowed for Medicaid, not for any other situation, or to just say we're going to continue it as a state regardless of the source of payment.
Yeah,
what would you do if a patient said they had Missouri Medicaid coverage, but then they no longer had that coverage and they had commercial Aetna? So you went from not the unauthorized practice of medicine to the unauthorized practice of medicine because you didn't have an updated insurance card.
Missouri Medicaid's your secondary, which often happens. Which rule applies on that visit then?
Yeah. So I'm not even going to attempt to guess, or I'll look it up and I'll confirm after this, because who knows what if I try to guess.
Well, this is the kind of stuff that just fascinates me.
It does. Yeah.
And the policies and how the federal government and the states can sometimes be at loggerheads on things. Yeah,
absolutely. It certainly creates an interesting roadmap for hopefully never having to go through this 1135 waiver process again, but just the implications of whether they did or did not get a state plan amendment or a waiver, and how that affects the wind down is really interesting. Excuse me. There's also an updated FAQ, the links here that you'll get on when the slides come out from Missouri Health Net, specific to audio only services. These are codes that I remember, 99441 and 443. So these were used, they can be used in place of the office visit evaluation and management codes when you are delivering a service via telephone only. Medicare expanded its coverage to allow payment for those codes when an E&M service was delivered audio only, and then bumped up the payment for those codes to mirror the level that would have been paid if an office visit code had been reported. And that happened all the way back in May of 2020. Missouri Health Net, Missouri Medicaid, their FAQ says do not report those audio only phone codes. Instead, bill the code for the office visit with place of service 02. because inherent in that place of service 02 for telehealth, they're telling us in the bullet point above that they're allowing the use of telephone, and that coverage will continue as of today, as of at least 1/11. That was what they were anticipating doing. Couple of the updates that happened, I'm not sure why I've got a gap there. Couple of the updates that happened, or the flexibilities that occurred, that again, as of right now, these would continue unless and until we have a hot tip update or a bulletin update, or so definitely keep those pages bookmarked. Well, child checks can be provided via telehealth, and that was applicable to both the fee-for-service Medicaid as well as the NCOs in Missouri. Hospital can bill the facility a facility fee for a telehealth service. Therapy providers could deliver telehealth under fee-for-service and the MCO for Missouri HealthNet. Oh, there we go. It was an image. That's just some guidance on how that hospital facility fee would be reported on the claim forms, both on the professional side as well as the facility fee on the UBO4. Then let's see, this would have been April of last year. So strange to think that was nearly a year ago now. Added some coverage in the behavioral health arena for Missouri HealthNet. This was psychiatrists, APRNs, social workers, etc. Allowed coverage for their services via telehealth if the patient was in a residential or other inpatient location receiving behavioral health via telemedicine. They had a slight difference on the way that this was reported, and it's different in Missouri Medicaid than this reporting would be in Kansas Medicaid and for Medicare. They did require a GT modifier, which was our telehealth modifier that we had used years ago before place of service 02 was even created. So in that very unique circumstance, there was a special reporting requirement. Waived the requirement for an established provider relationship to deliver telehealth. And Christy, we had a really good question about this come in to the HTRC email address just a few days ago. So I wanted to talk about this piece a little bit more here as well. At the onset of the COVID public health emergency in Missouri, we had a requirement that there had to be an established provider-patient relationship in order to deliver telehealth. There was a flexibility created for that as part of the executive orders. However, we then had a legislative change to permanently effectuate that. So the statute in Missouri currently says that you can establish a provider-patient relationship via telehealth. There are two sort of caveats to that language. The technology that's used has to be appropriate to establish an informed diagnosis. It does not define or limit the type of technology that is used. But it goes on to say, and this is under section 1146, if you're looking for this language, it goes on to say that not only does the technology have to be appropriate to an established and informed diagnosis, and also that the physical exam would have been consistent with what would have been rendered in person. So the "and" could suggest that not only does the technology have to be appropriate, but there also has to be a physical exam, potentially. I kind of read that in light of other language in section 1146 that says it has to be consistent with the standard of care. So there may be certain types of services where that physical exam may not necessitate a video component to it. And I'm reading different articles from American Medical Association, different professional guidelines on what the physical exam looks like during a telehealth visit. There are components of a physical exam that you could collect that wouldn't necessarily require a video component. And potentially reading that full section 1146 together, If the physical exam that you're delivering through a technology like audio only is consistent with what you could do in person, that could still potentially meet the requirement. It does not specify that it has to be audio visual. So there may be different interpretations on that, from more liberal to more restrictive, more conservative interpretations. Some of the examples that I found that I thought were a really good way to look at how that physical exam piece could still be accomplished is asking the patient to take their own weight at home, helping them take their own vital signs, coaching them through respiratory rate, coaching them through if they have a pulse oximeter, or taking their own blood pressure. So the vital signs, the constitutional organ system for the physical exam piece. In behavioral health, I think a good example of that you could discern potentially through an audio communication technology is judgment, insight, alert, oriented. All of those elements of the psychiatric or potentially neuro components could possibly be obtained through an audio only session. So the takeaway, I think the big takeaway is that it has to be consistent with what you would have done in person and consistent with the standard of care. So that's something to keep in mind, that is now a permanent flexibility, a permanent option in Missouri, statutorily created, that the provider-patient relationship can be created through telehealth. Oh, geez, there we go. It would have been a lot easier if I would have fast forwarded to this slide rather than trying to remember the exact language. But here in section 2 is where that language is. The technology is sufficient for an informed diagnosis, as though the interview and physical exam has been performed in person. So can you establish an informed diagnosis as though vital signs, psych, neuro, whatever that physical exam would have been done in person? In light of 1.3, that just says that you can have a telemed encounter if the standard of care doesn't require an in-person encounter, I think you can read those together to be consistent. Certainly that is not a formal legal opinion, but one possible interpretation along the spectrum of liberal or conservative that you may want to think about. So continuing on with Missouri and looking at some of the MCO policies for home state health, they've updated some of their guidance, and I've got a link here to where their current telehealth policies are. Home state health, it doesn't have a ton of information on their site, and other than saying July 1st of last year, any waivers of prior authorization requirements went away, and prior authorization is required again for those services. Essentially, the rest of their guidance says we're going to follow Missouri Health Net. So that's helpful in that we don't have a lot of variation for home state health and how they will cover or how they want certain telehealth services to be billed. United Healthcare, I felt like, had the best, most comprehensive of the 3 MCOs in Missouri that really gave some detail on what their telehealth policies are. There are 2 sites here with links to what their current status is that I thought was really helpful. And they break it down by different plans. So Medicaid, Medicare, Medicare Advantage plans, and then their commercial plans, how they're handling this. And United Healthcare says that for all United Medicaid plans, any originating site or audio visual requirements under the reimbursement policies are waived. Meaning, if there's a requirement under their typical telehealth policy that a patient be located in a certain place, like a physician office or a hospital, those are waived. The patient can be at home. If there's a requirement that it be rendered through audio video technology, that requirement is waived. Audio only could be sufficient, as long as it's specific with state regulations, as long as the live video system could be billed for members at home or at another location, essentially deferring to Missouri Health Net policy on that last piece. For one sort of caveat for United Missouri Medicaid is that for the therapy disciplines, for chiropractic, home health and hospice, they do want audio video technology, not audio only for those telehealth services. Another link here, and this is just a list of the eligible distance site practitioners for United. They're going to follow CMS policies on the current list of, eligible distance site practitioners. Thought I was going to have a coughing fit there, which of course through Medicaid or Medicare right now also has some expanded flexibilities for the therapy disciplines through the end of the public health emergency. And for United Missouri Medicaid, the MCO plan, it says while any 1135 Medicaid waivers are in force with CMS, care providers can continue to use phones that have both audio and visual capabilities for Medicare, for group market plans during the public health emergency. And with CMS, in terms of Medicare plans, there is a blanket waiver that didn't require an 1135 waiver request to do that, to allow phones, to allow audio only services. In terms of the scope of services that United Healthcare would pay for telehealth services, they would reimburse everything that's on the CMS covered telehealth services list for the duration of the federal public health emergency. And remember that Medicare covered telehealth list has significantly expanded for the duration of the public health emergency, with a number of services that will continue through at least December 31st, 2023, regardless of whether the federal public health emergency ends sooner, unless they become permanent telehealth services between now and then as well. Blue Cross MCO for Missouri Medicaid, the Healthy Blue plan, doesn't have much information on its website at all. It does have a brief FAQ on telehealth, but essentially seems to be deferring to Missouri Health Net policy in terms of what services are covered, how they're covered, and the scope of coverage and the billing formats for how you would submit those claims. One FAQ that I think is helpful, where audio only services are still on the forefront of everybody's mind with telehealth: will Healthy Blue, the Blue Cross MCO plan for Missouri Medicaid, cover audio only services in addition to audio visual? Right now it says yes. We're following the communication on telehealth by Missouri Health Net that says that coverage will continue. So that's Healthy Blue's current policy on that. Jumping back to Kansas Medicaid for a moment, this will kind of go through some of the details on what was added through the public health emergency. I won't go through these in detail again. We had a session back in May of 2021 walking through all of those elements in particular. The big picture right now in Kansas is that these policies continue in effect unless and until they are rescinded. And as of yesterday, I could not find any bulletin or any policy or any update to indicate that those telehealth policies have been rescinded yet. And in fact, in Kansas, their state of emergency at a state level has been expired for quite a few months now. I want to say it was back in May of 2021. So I continue to kind of check those policies with KMAP, and there's not an indication that they have or are going away. No advance notice of a termination of effective date. So all of those flexibilities that were added during the public health emergency, allowing home as an eligible originating site, allowing certain services to be delivered via both televideo and telephone audio only services, continue in effect, at least as of yesterday, to be allowed via telehealth as well. And this is just reiterating some of those policy bulletins and what they allowed. I want to make sure I get to Oklahoma here for the last few minutes. So for Oklahoma Medicaid, there have not been updates since we last talked about Oklahoma Medicaid coverage. The only updates I could find on the website were that June 1st of 2021, the use of telehealth for physical therapy ended in terms of Oklahoma Medicaid coverage for that. They removed that flexibility or expanded coverage. So just to kind of reiterate what did happen during the state of emergency for Oklahoma Medicaid, they had some expanded telehealth coverage. Apparently, PT via telehealth has been removed, but I didn't see any policy bulletin updates indicating that other services that had been allowed as expanded coverage because of the state of emergency have also been removed. I will say, though, that Oklahoma Medicaid has changed their website in the last couple of years, where a lot of those policies may be behind a firewall through your provider portal that you have to log in and access. So some of those just may not be publicly available on their website any longer. Oklahoma Medicaid, a little bit different than Kansas and Missouri Medicaid, wants the use of the GT modifier that Medicare, Kansas Medicaid, Missouri Medicaid, with just a few tiny exceptions, we're not using. So that's kind of a unique nuance if you're in Oklahoma or on the Oklahoma border providing services that are covered by Oklahoma Medicaid. They do, though, allow audio-only telehealth services that are rendered by telephone if the member doesn't have access to the audio-visual telehealth equipment. What that signals to me is that somewhere, somehow, there should be a notation in the patient's record that they didn't have access. That may mean they don't have a smartphone or they don't have a webcam. They don't know how to use the technology. They don't have sufficient bandwidth or Wi-Fi access to use the video component. But for compliance purposes, I think it's always helpful to notate that in the record to just check the box that you've addressed that compliance component if you're going to be doing an audio-only telehealth service. They do allow coverage for the audio-only codes, the 441, 442, but again, I'd have that notation in the record why you are rendering the service as an audio-only service when you're billing those codes, because they have specific codes in Oklahoma Medicaid, where Missouri Medicaid says, forget about those unique codes, just bill the office visit, just bill the other E&M code that you would normally report. For Oklahoma Medicaid and other payers that allow those codes, it also makes it really quick and easy for data analysis for auditing purposes. If they ever wanted to check and see whether you had verification that the member didn't have access to telehealth services, it's really easy for them to request and pull those charts for those audits. Documentation needs to indicate why telehealth was utilized if the service was not reimbursed as telehealth prior to the state public health emergency. And it also waived the requirement for telehealth to be provided to established patients for Oklahoma Medicaid. And again, I didn't see, at least on the public website, any changes to that policy about the provider-patient relationship via telehealth either. So I think we have 3 minutes left. I actually finished early and I'm not holding you over 2 minutes late over your lunch hour. So I'll pause there. If we have any additional questions in the chat, please ask those. I'm happy to answer those now or try to answer them and get some follow-up information out after the session if we need to.
I'm not seeing any unanswered questions in the chat. I will put the email. If you have any follow-up questions, you can send them to us and we will route them directly to Rochelle to get her guidance on those.
All right, and stay tuned. I'll try to keep Christy and Evelyn and Robert updated as we learn more on Missouri Health Net's policies, bulletin changes, what's happening with Kansas's potentially temporary 15-day, potentially extended longer state of emergency, and what impact that may have on our coverage and our licensing for telehealth in Kansas as well. So Oklahoma, you all are kind of smooth sailing at the moment, but there may be more legislative updates, of course, as we go on through the year as well.
Thanks so much for helping us navigate, Michelle. Lots of thank yous in the chat, of course. So we really appreciate it.
Absolutely, absolutely. All right, I'll get these follow-up questions to you, Christy, and we can then send the slides out and hopefully some helpful information for Jason and Carol and Julie.